effects of the drugs and so forth. So we said, right, furosemide is a loop diuretic, and the function was, right, to block these specific channels, right? So this is sodium potassium 2-chloride transporter, and furosemide will basically block them, as I was showing you, right? It's going to come and block this receptor, transporter, I should say, co-transporter. And if I block this, right, the kidneys is no longer able to reabsorb, right, sodium, potassium, and chloride. So these ions are going to start moving through the nephron, right? They're going to start moving through here. And actually, where I was drawing it here, yeah, I was drawing it here, right? So as, right, furosemide blocks this portion here, right, more fluid is going to be escaping. Why? Because sodium, right, and chloride, right, sodium chloride is going to come and it's going to pull water along with it. So you have diuresis, you have natriuresis, you have caloruresis as well, right? That's why if you have caloruresis, meaning loss of potassium, right, a lot of patients who are on furosemide, they will be taking some sort of supplement, right, KDR, for example, a potassium supplement. And you got to be cautious, right, with these patients. If you give them a lot of, Lasix, right, be careful, right, that you are not only removing water, right, you're pulling electrolytes along with it, and you're pulling potassium with it. It's not a potassium sparing diuretic. And so they may have, hypokalemia secondary to that. One thing you want to be also cognizant, right? The moment you give Lasix, make sure you have a bedpan or a urinal available, because if you don't, right, the patient will basically, want to urinate, and they will do so on your stretcher. And so have, that available for them, right? Urinal or a bedpan if you're going to go ahead and administer this medication. What else is important to know for that? I would say, in the field, you don't know their electrolyte status. You don't know if they're fluid depleted or overloaded. I would honestly, it's very hard to give this medicine pre-hospitally in terms of knowing the person pathophysiology. So I would say, hold this off until the transfer to the hospital. If you're dealing with someone who has congestive heart failure, focus on your treatments in terms of CPAP administration, nitroglycerin administration, positioning, 12-lead acquisition, right, and optimizing their oxygen delivery, as opposed to, start giving them, Lasix and adjusting their electrolyte composition, not knowing, what's their baseline and what's going on with them. Right? So this is how it comes packaged, right, and you're going to be administering it via IV, right? It's a medical control option. So here in your protocols, right, this is when you suspect patient is in acute respiratory distress. Particularly, we're worried about acute pulmonary edema, right? They'll say, call for medical control, and you could give 20 to 80 milligrams IV. This is the medicine that you're giving, right? Furosemide, and the other name is Lasix. And the way, again, it works in the kidneys in the tall ascending loop of Henle, right? So here, let me just go back so you guys are clear, right? So this was the, right, thin descending loop of Henle. This was the pin turn. This was thin ascending loop of Henle. And the moment you come here, this is called the thick ascending loop of Henle. So thick ascending loop of Henle, it has these transporters, sodium, potassium 2-chloride. And this is exactly where furosemide will exert its effects, by blocking these channels, right? And then, right, you have diuresis with natriuresis. All right, so this is the medication. Any questions about this one more time? All right, so no questions. We kind of already spent this time talking about this, but just to outline, right, this is your entire circulatory system here. Here they show you particularly, right, as the blood flow is going to the kidneys, and we already know, right, about 20% of your cardiac output is going to your kidneys every minute. That's about 1 liter, right? And out of that 1 liter, we said about 60% is the plasma volume, and 60% of 1 liter is about 600 mLs. And 20% of that, which is 120 ml, is what essentially is going to go into the kidneys themselves, right? Which is going to be filtered, right? And solutes reabsorbed. And then finally, out of all these 120 mLs, we have per minute, I should say, about 1 ml per minute is your urine output. and that is about roughly about 1,500 ml or 1.5 liters, right, of urine you make per day, right? And I know some of you guys believe it was 80 ml, but as you see, right, it's you will basically be carrying, you know, like a Foley catheter with your living in a restroom if you were making 80 mLs an hour. Even, like I said, even the most strongest diuretic, if it increases your output by even 4 times, right, 4 mLs per minute, that will be a considerable increase in the amount of urine you're producing per day, right? And the goal, I guess, certainly, right, of the diuretics is to decrease end-diastolic volume. So less blood is coming to, right? If you decrease the amount of blood that's in, you know, in your veins, less of it is going to come into your general circulation. So this is how we help those patients in congestive heart failure, right, to decrease their end-diastolic volume by giving them diuretics, right? So this was this. The other important thing that I also want to emphasize, which I said, right, so we talked about the renal angiotensin aldosterone system, but also you guys remember in a setting of low blood pressure, what other system is activated? Right? So in the setting of shock, right, you also have your sympathetic system, right, the fight or flight response. And that sympathetic system, right, is also going to work on the kidneys. Kidneys have beta-1 receptors, right? And the stimulation of the sympathetic stimulation will also going to secrete this epinephrine from the adrenal cortex to go into circulation. And in the short term, again, this is great, right? Why? Because it is going to cause vasoconstriction, maintain the blood pressure. But in the long term, we see how this was bad, right, for us. This was basically in the body, right? The carotid sinus and the aortic arch, which is essentially the better receptors that stimulate the secretion of norepinephrine. How do they work? They work under the stretch response, right? So if you have very high blood pressure, these sites are going to be heavily stretched, so they will send less signals. But the moment you have low blood pressure, right, they will be less stretched, and so more signals are going to be sent, stimulating the norepi release, right, and activation of the sympathetic system. Here, why I have this here, right? This was basically my question in the respiratory system. Where exactly is ACE enzyme produced, right? And I think Ian said, right? Ian said in the capillaries, right? That's what you said, Ian?
Yeah.
Yeah. So
Yeah.
we see, right, the here we see the red blood cells, but here we see the endothelial cells, right? And this is where it's produced. And it makes sense, right? Because though the angiotensin 1, which was made by renin and angiotensinogen combination, has to circulate through the blood, right? It cannot be like in your alveoli because that's where air is, right? Because if we had that in the alveoli themselves, right, that will interfere with the gas exchange there, right? It cannot definitely be in your cartilages, in your trachea, in your bronchi. It's not found there, right? It's definitely found in the endothelial cells, right? The ACE enzyme. And also, right, when you give ACE inhibitors, right, they have to go they will have to go into the central circulation. They have to reach the sites in order to disable, right, or inhibit the ACE enzyme. So all of that makes sense, right? And now, right, we want to talk about a little bit about the acid-base balance, right? We said besides the blood pressure regulation of the kidneys, it also controls, right, your acid-base balance, right? So you guys, I mean, at this point, we know, right, blood pH is 735, 745. So let me ask you this, right? How do you think a kidney maintains your acid-base balance? How does it do it?
Like a homeostasis type of thing?
I can hardly hear you. You want to say it again? So if you're yeah, go ahead, Ted.
By maintaining the proper ratio of like calcium and like potassium, so it keeps it at like 7.3. You know.
So truly speaking, right, it's more of, you know, hydrogen and bicarbonate right, ratio. You remember in the respiratory lecture, right? I was showing you this, formula, like this. I was saying carbon dioxide, right, was combining with water, right, and this was turning into carbonic acid, and this can also further dissociate into hydrogen ion plus bicarbonate. You guys remember this, or this looks foreign and unusual?
Yeah,
You guys remember this, right?
Yeah.
So in the respiratory system, right? Let's say somebody is acidotic. We could use let's say we use diabetic ketoacidosis. We use DKA, right? DKA patient. And patient is acidotic. Let's say their pH is dropping. Let's say their pH right now is 7.29, right? So they're in acidotic state, and the body is going to respond by compensatory mechanism. So your respiratory system is like seconds to minutes, right? But your renal system is hours to days. So the first system that gets on board would be which system? The respiratory system, right? Minutes, right, to hours. The renal system comes on later. So if I'm acidotic, right, I want to get, acidosis, right? I have a lot of hydrogen in my body, right? Make sense? So what I want to do is I want to move this system into this direction. I want to get rid of my carbon dioxide. If I start to get rid of my carbon dioxide, right, more hydrogen ion is going to get removed, right? Well, how is it going to get removed? It's going to get removed by combining with bicarbonate. We're going to make carbonic acid, right? And then this will dissociate into CO2 and water. And right, and if we are in respiratory, right, condition, we're going to blow off this, right, CO2, right? We're going to blow this off in order to compensate, right? This is our compensatory response. But the kidney does something very, very similar, right? What does the kidney do, right? So in the kidney, in the setting of acidosis, there is increased secretion of hydrogen ions, right? You want to increase it, and you want to reabsorb, right? You want to reabsorb your bicarbonate. So, and the formula will be exactly same way, right? So if you come to the kidneys back here, you draw, right? So what the kidney is going to do, right, with the same format, it wants to get rid of the hydrogen. So you want to have the hydrogen losses. At the same time, right, you want to have bicarb reabsorption into the interstitium. Why do you want to have this bicarb reabsorption? Because this bicarb can then come and combine with further hydrogen, right? It can combine with further hydrogen. Take a different color so you guys can see. So if in the interstitium, this HCO3, right, that's being reabsorbed can combine with more hydrogen, this is going to in turn make it into, right, carbonic acid, and this can further dissociate into water and CO2. And we know CO2 can go in the lungs, right? So this way how the kidney is helping. So this CO2 can get blown out in the lungs, and this hydrogen here, right, can get removed with urine, right, making acidic urine, right? So the formula is exactly the same. How the major distinction is this: it takes hours, days, and weeks, so much longer time for the system to get activated in order to facilitate the removal, right, of that. So this is, right, this is why they call it metabolic, right? Metabolic, it's utilizing the kidney's response. It's slower than the respiratory response, but it's definitely going to come on board, right, to correct our acid-base imbalance. So this is how the kidney is helping us. Same formula, right? Same formula, right? So in the setting of acidosis, it wants to retain this part, the bicarb, and it wants to get rid of this part in the urine, making acidic urine, hopefully to get the pH back into the normal amount, right? So this was basically me showing you the kidneys, right, and how it goes into the actual nephron. And nephron I kind of drew in the pictures. They they draw this, right, with all these afferent arterioles. They draw this with all these vasorector circulatory system. But the reason why they do this is because it has to bypass, right? It has to go down to get secretion, filtration, and reabsorption to occur, right? And there's many nephrons, right? We talked about There's about 1.2 per kidney, but I made it very simple diagram for you guys so you guys understood in terms of the flow, right? So, so here I think it's a little. This is they show you two of them together, right? They have two glomeruli here, and they show you all that. But we pretty much with one you could understand the concepts, right? In terms of your kidney and nephron response, right? We talked about macula densa and Pulkisson cells, which are found by the afferent arteriole. So what is the function? What was the function of this macula densa and Pulkisson?
Produce running.
What were you saying, Angel?
They produce running.
They produce renin. Excellent. So together, all of this is known as juxtaglomerular operators, right? Pulkisson was the baroreceptors. Macula densa was the chemoreceptors. Pulkisson sense drop-in of flow of blood and pressure. Macula densa senses the drop of sodium. The moment they get that, they secrete renin. That's their, together that's they do it. And they are located in the, if you see the afferent arteriole, it's very important. Why? Because this is where exactly blood flow starts to come into the kidneys or the glomeruli, right? Or the Bowman capsules they show here. So you want the pressuring measuring device close up where the blood is going to enter, right? And this is what we want to see, right? Some of the stuff I kind of drew out, but here they have the responses, right? So this was the sodium potassium, let me circle it. This was the sodium potassium pump, right? And the way it works, right? It pumps 3 sodium out for every 2 potassium in, right? In the setting of aldosterone, right? More of these channels are going to be expressed on the basolateral side surface. This channel we specifically talked about, right? Normally what it does, right? It pumps sodium, potassium, and 2-chloride out. But in a setting of furosemide that blocks this channel, right? It's no longer working. So that's what we see, right?
And sorry, Nikolai, I forgot the name of the channel. What is it again?
Of this channel?
Yes.
Sodium potassium 2-chloride co-transporter. Sodium potassium 2-chloride co-transporter. This channel is called sodium potassium ATPase. And this, by the way, this is found not just in the kidney. This is found in the cardiac cells. This is found in your neuronal cells. And this, believe it or not, uses about 20 to 25% of the all ATP, right? You see how they show ATP here? Adenosine triphosphate, right? So what do you think in the setting of shock, right? When you have anaerobic respiration, your mitochondria is not making ATP. Do you think all of this is working? Right? Not working. So your kidneys may also not get enough ATP, right? Your kidneys don't get enough ATP, right? Plus in the setting of shock, what's going to happen, right? You become acidotic. You start having azotemia, right? Azotemia is retention of all these solutes that should have been removed, right? Especially like, urea. And person goes into metabolic acidosis, right? And then we have to correct the underlying condition, right? But these are the receptors here and the location of where they're located, right? So we talked about this, right? So as I think you kind of see, right? So think about this, right? I gave you aldosterone. Right? I gave you an excess of aldosterone, or aldosterone is being secreted. So this aldosterone, as I said, right? What does it do? It comes to the cell. It makes more of these sodium channels, makes more of these potassium channels, and more of these, right? Sodium, potassium, ATPase. And now you could see, right? Let's say blood is coming in with these solutes, and more of sodium is being pumped out under the setting of aldosterone. Because why? I want to retain salt and water. This sodium is going to be pumped out into the interstitium for salt and water retention. This potassium is going to come in to get secreted, right, in the urine. So in the setting of, right, aldosterone, what you're going to get salt and water retention, and you're going to get kaliuria, right, losses of potassium in the urine, right? So that's what's going to be occurring, right? So we talked about that. This is just, right, little, location, right, of these, right? So thick ascending loop of Henle, I kind of plenty, right? Thick ascending loop of Henle. This is where we found our, right, furosemide blockade, right? What else, right? So this is, not that you need to know this, but how does aldosterone exert its effects, right? As I was saying, it's going to come, right, into the cell, and it's going to signal this nuclear machinery. So nucleus has DNA, right? And from DNA, it's going to make RNA, and then specifically messenger RNA is going to be becoming these proteins, which is essentially is going to translate into these channels, which are going to get embedded into the walls, right? What's very important for you to know, the channels that get embedded on the luminal side that's leading towards urine formation versus the channels that are being made on the basolateral side, which is going to reuptake into the interstitium, very different, right? The luminal side that's going to make urine, this is where these potassium and sodium channels are going to be made. But the basolateral side that's now coming into the interstitium, this is where you have the sodium potassium ATPases, right? This sodium potassium ATPase will never ever be made on this side. They're always made on the basolateral side of this principal cell. Right? So this is basically just to show you how this works. We see the mitochondria, right? Why is this important, right? So mitochondria is making these ATP. Remember in the lecture, right? If you have a high amount of glucose, you have high amount of oxygen, we're making, about 32 ATPs, right? And this is what is helping drive these sodium potassium ATPases. In anaerobic respirations, when we do not have oxygen, right? We only make about 2 ATPs. And so you could see, right, this is going to fail, right? They're not driving these, right, potassium pumps, sodium potassium ATPases. So you have retention, right? And this is not working. So, right, person may develop all these conditions such as metabolic acidosis, azotemia, right? And all these problems that occur with that. That's why we tell you, right, somebody in a, what are the primary things, any shock, doesn't matter what shock, right? What are the goals in shock management?
Manage the person's perfusion.
What are we, like, tell me, like, in the basic layman's terms. Somebody's in shock. What am I doing?
Bring the blood
Trying to
pressure.
keep their body as normal as possible.
Okay.
But what am I, like, give me the treatments. What am I doing?
Oxygen.
Why? Because you want to get that oxygen, right? So ATP is made. Make sense? Because in the setting of low oxygen, right, you go into anaerobic respiration. In the setting of oxygen provision, you make more ATP, so you could drive the body's channels, right? All these sodium potassium ATPs. Okay, so we give oxygen. What else we do?
Fluids.
Maintain blood pressure.
Very good. Fluids. Why is it very good? We give IV fluids, right? So in the setting, right, hopefully, right, this angiotensin aldosterone system is going to start working, but it takes hours to days for it to kick in, right, fully. In the initial phase, you only have that sympathetic fight or flight response, the episurge. We give fluids to maintain the blood pressure, to maintain the flow to the vital organs, right? So we give IV fluids, right? Isotonic, right? Isotonic IV fluids. You want to give enough fluids to maintain the blood pressure. You don't want to overdrive them above it. MAP of 65, right? What else we want to do, right? This is especially you guys are taught, right? In BLS, right? Keep the patient warm, right? Remember we talked about that? Keep the patient warm, because in a setting of someone who is, let's say, hemorrhage, right? Stabbing or trauma, cold patients do not clot, they bleed, right? So they bleed, and we keep them warm, right? I would even urge you, you're in the ambulance, turn up the temperature that you're, like, turn up the heater so you feel uncomfortable. The moment you feel uncomfortable, that's probably good enough temperature for someone who is losing a lot of blood. If they are warm, right, their coagulation system is going to function, right? A lot of times we bring patients to the hospital and they put them in a cold resus room, right? They're shivering, right? Those patients are not going to clot. So the basics, right? And then before, right, they were telling you guys to elevate the legs. That was basically just to mobilize the fluids from the legs to go into the, right, central system, central organs. Some studies show that it's not really efficacious, but I know it works because I can tell you from firsthand experience, I had patients who had, like, GI bleed, right? And I would lay them down flat, raise their legs, give them IV fluids, and their status would improve. So, I say from the empirical standpoint, that does work, because I had those experiences firsthand. But those are the basics, right? And why we do this, as you could see, right? It makes sense now that we talked about all that. By the way, You know how if any of you done rotations in the ICU, right? They always measure urine output. They always measure urine output. They get the Foley. They're always coming in. They measure urine output. They're like, what's the urine output? What's the urine output? Why do you think that's important?
Because
If
they
you're
want
not,
to make sure that your kidneys are perfusing and you're getting rid of the necessary waste out of your body.
Very good. So one of the markers that your shock state is improving is return of kidney function, right? So in return of kidney function, your kidneys start to make urine, right? Means that there's blood flow, right, circulating through the kidneys. So that's another marker in the shock, right? That they're doing it. I remember, we're so worried about the blood pressure. What's the blood pressure? What's the blood pressure, right? But truly speaking, right, it's the urine output. If you have improvement of urine output, this is how you know, right? You have improvement of shock status, not the blood pressure. All right, so this was the aldosterone response. Here we have the effects of potassium, right? Mainly, I want to focus on, in this setting, right, in the setting of hypokalemia, right? If you have losses of potassium, how would you have potassium losses? Either you gave a lot of Lasix, right, your medication, and the person is losing a lot of potassium in the urine, or the aldosterone effects, right, with loss of potassium. So you're going to be in a hypokalemic state. What are you going to see, right? You're going to see this flattening of the T waves, right? And, right, it's good to correlate. Like what I'm saying to you, just because you got the EKG doesn't mean, it's all that. But if you start to combine, right, you're like, all right, the person is on, these loop diuretics, or we gave him extra loop diuretics. Now we're starting to see this EKG forming. The guy is passing a lot of urine, right? So maybe you start to put things together, right? On the other hand, right, a lot of these patients who are prescribed furosemide, they're going to usually put them on, this medicine. It's usually a potassium supplement, right? And so why they do that? So that potassium is resupplied, right? Because you don't want to lose and then, basically go into this condition. And, as you guys know, we cannot rapidly infuse potassium. We got to give it very slowly, right? Because if you give it too fast, you may cause the patient to go into arrhythmia and die, right? So give it slowly, and that's why we don't want to be at very, very, very low amounts, right? For this reason. So, okay, now we get a little bit in depth of the nephron, right? So we talked about afferent arterial, right? This is where the blood is essentially coming in, right? Going into the kidneys, and then the efferent arterial will take the blood into the renal veins, back to the circulation. And these are all the loops, right? The descending loops of Henle. These are the thin loops, right? This is the thick loop. One thing important, right? As you come over here, right, your plasma that's coming here, what do you think is the osmolarity of the plasma? Osmolarity when it's here, roughly speaking. So you remember your normal osmolarity about 290, right? Milliosmoles. Or maybe you could round this number to 300 if you want to, right? About 290, right? But there's something I want to note about these parts of the nephron, right? So this part of the nephron allows both the secretion of your solute particles like sodium, chloride, right, potassium, and it also allows the secretion of water. So it does this both ways. As you're moving down here, the amount of osmolarity found in the interstitium is going to increase. It's going to become 500, 600, 1200. So no more particles can escape here, because if your normal osmolarity is 300, they cannot escape. So some of the particles start coming in here, right? And you also have fluid coming out. So as you moving down here, more solutes are being loaded, so the urine becomes more concentrated. As you make your way here, this part of the nephron, it's water insoluble, right? So there's no water that can move out. The only thing that can move out is the solutes. And as this hypersecreted solute concentration moves up, the solutes are being secreted out, but the water is not. So as the moment you come here, you have dilute urine at this point. The reason why you have dilute urine is because, right, the solute particles were able to leave, but this was water impermeable. And the last part of the nephron, right, this collecting duct, as I said, it's usually water impermeable. The only time it becomes, yeah.
Oh my god. Oh shit.
Aaron, you had a question?
No, sorry.
Okay.
The car
So
disconnected.
this part is usually water impermeable, and it's only going to become water permeable under effect of a specific hormone. Which hormone is it? And it's going to start to,
ADH.
yeah, aquaporins. So under the influence of ADH, right, it's going to, only then, right, it's going to form these aquaporins to reabsorb water, so you passing very concentrated urine. And what it does, it reabsorbs H2O into the interstitium, right? We also give ADH, right, a vasopressin. We used to give it in the setting of cardiac arrest. It was in place of the first epinephrine. So vasopressin was given. The goal was to do this, right, to reabsorb water, to cause vasoconstriction for them, right? So ADH, antidiuretic hormone, another name is vasopressin. By the way, this is a good note, right? You notice how a lot of your medications, right, they're like milligrams, 4 milligram, 20 milligram, 400 milligram, or micrograms. If you look at your hormonal drugs, right, like vasopressin, right? What else? You got glucagon. They're in units. Insulin, right? So look at hormonal drugs. They usually come in units, right? Insulin, vasopressin, right? That you will see next time when glucagon. Next time we are in the lab, I'll show you guys. Right? So this is just the circulation, right? Showing you a little more in depth, but I think we kind of went over this. Parts of the nephron, we went over this, right? And what it does, collection duct, and so forth, right? This is what I was showing you, right? In your afferent arteriole, right? We have this juxtaglomerular complex, right? And how does it exert its effects? Basically, what this juxtaglomerular complex, and they show you, see how these cells, right? The purpose of this is basically there's macula densa and the Pulkison cells. Together, they make this juxtaglomerular complex, right? Juxtaglomerular apparatus or complex. And the whole job of them is to basically monitor, right, every second, every minute, right, what is the flow of blood into the kidneys. If the blood flow of blood is good, I'm not secreting renin, right, because I don't need to do that. The moment blood flow is reduced, the moment blood pressure drops, all of a sudden these cells say, you know what, I gotta make sure I get my blood pressure up. I'm gonna secrete renin into the circulatory system. And this is where it does it. Makes sense because I want to have the baroreceptors exactly at the point where the blood is coming in. So here we see right where the location of it. We see the cells, right? And we see right the macula densa. They don't really point out the Pulkison cells here, but they're there, right? And this is where, right, this is occurring, right? Afferent arteriole, efferent arteriole. Exchange of your anions. I think we went through all the receptors, all the channels. So you guys I think should know sodium, potassium, 2-chloride transporter, right? Especially, right, location of it, which drug works on them. Furosemide, right? Furosemide, right? So remember, furosemide is the drug, right? That's working there, and the channels, right? And right. So this is what I was basically explaining to you, right? Here we see the osmolarity of the plasma that's coming inside, and here we see the osmolarity as it's traveling down, right, into the nephron. Here it allows both water and solutes to be exchanged. But as it makes its way through the pin turn and is going up in the ascending loop of Henle, all of a sudden it becomes water impermeable. And the only thing that can move out is essentially just the solutes themselves, right? The cations and anions. And as the blood is moved up, it's becoming less concentrated, right? and there's less particles in it. And as it comes here, right, it basically has less solute particles and it's dilute. And the last part of the nephron, right, is under the influence of ADH, and only then there's going to be more reabsorption of that, right? Antidiuretic hormone, right? So we see all this here, right? So just what are these abbreviations? So, this is the proximal convoluted tubule. This is distal collecting tubule, right? And this is the collecting duct where actual urine is going to form. I think I drew my nephron kind of like that, right? So you guys can visually see this occurring. Now, right, so this is what I was showing to you, right? The distal part of the nephron, right, the ending of it. This is under the influence of antidiuretic hormone. So it's usually, right, we see this is water permeable, water impermeable, and water permeable only under the influence of ADH, right? Antidiuretic hormone, right? Antidiuretic hormone comes, it will pull the water out of the nephron. If it pulls the water out of the nephron, you have a lot of concentrated urine that's being formed. When do you want to do it, right? Ideally in the setting of shock, right? I want to reabsorb my water to retain in my body. I don't want to pass dilute urine. I want to have concentrated urine. And this is what ADH does, antidiuretic. And the name makes sense, right? Antidiuretic, antidiuresis. So less of it is coming out. Right, this is just the same stuff, a little bit more involved diagram, right? But pretty much talked about all this. Right, renal cortex, renal medulla, ADH regulation on it, and all that, right? In terms of your pH balance, right? So we already know, right? Normal blood pH is 735, 745, right? And the kidneys, right? It wants to also regulate blood pH. Respiratory system, right, is under minutes to hours. Kidneys under, days, hours to days. The formula that you guys should be experts on is this: water combines with carbon dioxide, makes carbonic acid, dissociates into hydrogen and bicarb. You guys are sitting here, right? We give a drug, sodium bicarb. How do you think it works? You guys saw, right? In the crash cart, we were doing cardiac arrest. There was a sodium bicarb vial, right? We give it IV. How is it going to work?
It's going to push the equation to the left.
Yes. So we make more CO2. Make sense? Why make more CO2? The guy is going to breathe faster. If you ever give this drug when the patient is breathing and he has endotracheal tube and end-tidal CO2, right? And I push this drug, what do you expect to see my end-tidal CO2?
To go down.
In the initial phase. So imagine this. I got a guy, he's post-cardiac arrest, he's intubated, right? He has end-tidal CO2, right? And medical control tells you give him sodium bicarb for the pre-existing acidosis. And he's breathing on his own now. And I push my bicarb in the initial phases. As the bicarb is coming into the blood and it's combining with this with hydrogen ions, because the person was acidotic, it's making more, right, carbonic acid, and it's going to make more CO2. So the initial phases, you're going to see like rust conditions. You're going to see your CO2 jump up. So your end-tidal CO2 is going to be like 70, 80, until the person is breathing faster and faster. The moment he's driving off that CO2, eventually he's going to go back to like normal range, right? It's going to decrease. But the moment I push that amp, next time, if you're in the field, take a close look. The moment I push my bicarb and it starts to circulate, right, this numbers are going to spike. Anyone saw that in the field or have experience seeing that, doing that?
Yeah.
Yeah. So it will jump up, right? So this is how this drug works. Now here's my question, right? Let's say the guy is in cardiac arrest and he's not breathing at all, and I'm pumping him with this bicarb. Do you think it's really affecting his acidosis status? Probably not, right? Because he's not really breathing, right? I can't really drive out the CO2. The only way I'm driving this out, is by squeezing the bag, but the circulation is not as good. It's not really working well, right? So are you going to really change his pH balance by giving them bicarb in a cardiac arrest status that they're not back yet? No, probably not. If I cannot get rid of the CO2 by breathing, right, I'm not going to do it. Another case, you got a patient with diabetic ketoacidosis, and they're already breathing at a rate of 36. Their body compensating. I'm going to give them sodium bicarb. Do you think it's going to do much for them?
No,
Why not?
because the reason they're acidotic, you're not tackling the big problem that they're making ketones.
The
Maybe
the
little
problem
bit.
is not per se. You're correct. You're not checking the problem, but the problem is how much more can they breathe? Because the way this drug works, it has to convert right your hydrogens or your protons into carbonic acid and drive them off as CO2. If I'm already breathing at a rate of 36 as a diabetic ketoacidosis, right? Somebody who has this, how much more can you breathe? Can you breathe, 50 times a minute? Probably not, right? So giving them this drug in that setting probably not going to cause much difference. That's what I'm trying to say to you guys, right? The other thing, right, that you want to see here, right? So this was the respiratory component. Kidney does the exact same thing, right? But the way kidney is going to do this is same formula, but what it's going to do is going to basically get rid of this hydrogen ion. It's going to reabsorb this bicarb into the interstitium, right? And this removal of hydrogen is going to cause, right, urine to become more acidic. So it's going to be passing acidic urine. It's going to be reabsorbing this bicarb into the interstitium. So this, right, can react with hydrogen in there, right? Make more of carbonic acid, right? So this can dissociate into this and get rid of it in the lungs. So hopefully that makes sense. This takes, way longer to kick in, right? It's not like, right away. So the renal system, right, that's activated, it's hours to days. And respiratory is basically minutes to hours. It's very fast, quick response. All right. So we talked about this, right? Intracellular, extracellular fluid, carbonic acid, bicarbonate buffer system, right? The other stuff we talked about, right? The similar system when we did our components on the hemoglobin, how it carries the bicarb with it. So I'm not going to spend some time, discussing it, but the red blood cells, right, have the same exact formula, right? This is how they exchange the CO2, right? Same exact formula carried in the blood, right? Dissociates into carbonic acid, into hydrogen and CO2. So we see this, right? So the major thing being, right, in terms of the hydrogen removal, right? How does this work, right? So one pathway is to make the CO2 to get rid of the lungs. The other one is basically to preserve your bicarbonate and get rid of hydrogen in the urine. And right, this is basically, right, it shows you here, right? So kidneys, right? What's the role? Secretion of hydrogen ions, right? They secrete this hydrogen ions and reabsorb the bicarbonate. And this helps to restore this pH balance, right? Hopefully back into the normal state, right? And obviously, right, as I think Syed was saying, right, how do you correct? You got to treat the underlying condition. So Syed, how would you, so DKA, what's the underlying problem?
Hyperglycemia.
Okay. Is it hyperglycemia? What's the main problem?
The
They're
cells can't use glycose. Oh, sorry. Glucose.
they're digesting the fats for energy and making ketones.
Very good. So ketones, right? Basically, the ketones are acidic, and this is what's contributing to this acidosis. How do we stop acidosis?
You allow the cells to use glucose.
How will you do that?
Get some insulin in there.
Very good, right? So the reason insulin is given, right, is not to reabsorb sugar. The major reason you give insulin is to stop formation of further ketones. The moment you stop formation of further ketones, you arrest that process, right? You stop that process, no more ketones are made, right? The less acidosis is formed, and so you stop this process, right? And then you obviously, right, correct their electrolyte problems with replenishments of potassium wherever they need, give them fluids if they have, if they were, diuresing their fluids, right? Diuresis. and then you correct, right, their overall status, right, by looking at everything. So we look at their blood work, we look at their pH, so ABG, right? We do like consistent blood glucose, arterial blood gas examinations to see where they're at. But truly speaking, I'll tell you, right, the moment you correct the acidosis, right, their problem will start to improve. And the two systems that play a role there, right, would be your respiratory system and your renal system, right? And the respiratory system is going to get rid of that CO2. The renal system is going to work, right, to get rid of that hydrogen ion in the urine. And so the two systems work together to compensate, right? The major goal is to keep your blood pH in this range, right? So good. Right. On something else I wanted to mention, but I did not. So this here, they show you carbonic anhydrase. What is this? This is essentially, this enzyme, right, that's converting. Let me go back to this formula, right? So the formula was CO2, right, plus H2O. This was making our carbonic acid, and then this was dissociating into bicarb and hydrogen ions, right? This arrows basically shows the function of your enzyme, and the enzyme being carbonic anhydrase. So the carbonic anhydrase is basically what's utilized in forming this, right? So we see it here. That's why they wrote it, right? And how it works, right? So we see same exact formula, right? Carbon dioxide fuses with water. You make this acid, carbonic acid, and then, right, as the dissociation is occurring, hydrogen ions are being lost, right, in the tubular fluid. This is basically going to be urine. Bicarbs are being reabsorbed, right, through these channels, right? And so retention of bicarb will help us get the pH back into the normal location.